Good afternoon, everyone. Thank you very, very much for joining us, and apologies for the delayed start. The team's gremlins were doing their very best to sabotage proceedings, but we think we are ready to go. So thank you for hanging on in there. My name is Lauren Walker. I am an occupational therapist and I'm a professional advisor at the Royal College of Occupational Therapists. And I'm really thrilled to be co-hosting this session with my colleagues at the Chartered Society of Physiotherapy, who is Jackie Lidgard, and then my colleagues at the Royal College of Speech and Language Therapists, who are Claire Moser and Judith Broll. Next slide, please, Abby. I should also thank my colleague Abby, who is our slide wizard for the afternoon. So we'd love to know who's here with us, because we're using the webinar format. We can't see your faces or hear your voices, so please tell us that you're with us. If you've got your mobile phone handy, you should be able to scan the QR code in front of you, and that will take you through to, I promise you, a very, very short form that simply asks you which professional group you belong to, and how you feel about the intermediate care framework at this point in time, how familiar you and confident you are with it. There's a little hyperlink there. I should, I think, be able to pop a little hyperlink into the Q&A bar as well. Bear with me while I attempt to multitask. There we go. So a link should have popped into the Q&A for you. We are going to be recording this session for folks who aren't able to join us in the room, and they'll also be able to access these links. So please do just take the 60 seconds just to let us know that you're here and how you're feeling. Next slide, please, Abby. I've already introduced myself. Here I am doing the intros. Really delighted that Priya Umadat from NHS England and Laura Falter-Genthrop and Brenda Thompson from the Leeds Health and Care Partnership have given us their time today to share their wisdom on the intermediate care framework. And myself and Jackie and Claire will also be speaking about why we, from a professional body perspective, are really pleased that the intermediate care framework is out in the world, and why we feel very, very keen that we want you, our AHPs, our OTs, our physios and our speech and language therapists to be engaging with this, and why we think it's actually a really valuable and a really important tool for you in your practice. We will have time at the end after Laura and Jen and Brenda have shared their experience of using the intermediate care framework and bringing it to life and developing that work. We will have hopefully some time for Q&A. I realise we've started a few minutes late, so we'll do our best to squeeze that in. So please put your questions into the chat box, into the Q&A box. If we can, we'll answer some of those in type, and we'll hopefully have a bit of time for discussion at the end. So without further ado, I am going to bring Priya into the virtual room, and we'll hand over to you. So if we can bring up Priya's slides, please, Abby. Thank you, Priya.
Lovely. Thanks, Lauren. And it is afternoon. Good afternoon, everyone. And thank you for inviting me to present briefly to you about the national work that we've been leading and have delivered on intermediate care and rehab. My name is Priya Umadat. I'm the Deputy Director of Community Rehabilitation in NHS England as the policy lead. And I've also led well, in relation to intermediate care, I've led various pieces of work around the rehab enablement model and current work around workforce capacity, which I'm assuming colleagues on the call have actually seen the intermediate care framework and the rehab enablement model that's been published. So next slide, please. Just to give you a little bit of a background as to where this work comes from, and this is really important to set the scene, but tell you sort of how this is a sort of very strategic lever for you to sort of drive change locally. In January of last year, NHS England published the UC Recovery Plan. I think that was last year, that was the year before, actually. No, it was last year, with the key ambitions around the 4-hour target and ambulance category 2s. The plan was, and as I said, it's a strong implementation lever to reduce system pressures and improve flow. And one of the things it talked about was increasing or scaling up intermediate care and rehabilitation capacity. There were 5 priorities to deliver the plan. 4 of them resonate with the work that we've been leading, that you'll hear a little bit about. And that's number 2, 2 to 5, increasing workforce size and flexibility, improving discharge, expanding care outside of hospital, and making it easier to access the right care at the right point by the right skilled person. And all of that would have an expected impact on, number one, getting the flow at the front door sort of eased up and moving. Next slide, please. So in terms of intermediate care, I suppose what is the problem we are trying to solve with the intermediate care work? Many of you might know that, you know, across the country, there are thousands of people that are having to spend the night in hospital, in an acute hospital bed, when they should be recovering and rehabilitating at home, mainly because of lack of or poor access to that post-discharge recovery rehabilitation support. And we know the consequences this has around deconditioning, and we're talking about really older, frail population. And I'm sure everybody on the call is aware of some of the consequences of having our older people staying in hospital when they're medically fit or they're safe to recover at home. We've working on the intermediate care framework and rehab model. We have worked with 5 pilot sites and frontrunners to extract the learning from the work they've been undertaking and redesigning their intermediate care services. And that learning has, in addition to learning from other systems that we've spoken with, has contributed to the intermediate care framework and the rehab reablement model of care. So those 2 documents pull the learning from across the country. Next slide, please. So just a little bit about the rehab reablement, the model. To increase rehabilitation capacity, this new model was developed with multi-professional and multi-agency input from national, regional, and local stakeholders across sector and settings. And some fundamentals of the, you know, of the work or the model was it's aimed to support an increase in intermediate care and therapy-led rehabilitation and reablement by optimizing access or the use of our registered workforce and maximizing the use of our unregistered therapy workforce, our support workers and practitioners. Ensuring anyone who requires rehabilitation post-discharge is able to receive this in their usual place of residence or as close to home as possible. The model describes activities that need to happen, starting from in-hospital to delivery of their rehab reablement interventions to support their recovery out in their homes. And it describes multidisciplinary teams working in very integrated ways to ensure that right skills and expertise is accessed when that's required. So in essence, what we are describing is how to support an increase in high quality, timely and safe rehabilitation and reablement interventions by utilizing the workforce and the expertise we have differently, driving a more improved productive model. The model itself that we described is independent of or agnostic of settings, and it applies to both bedded and non-bedded pathways. And I think the reason we did this is largely because I think that the bedded pathway tends to be an artifact created because of a lack of capacity out in the community to deliver the interventions at home. The principles of the model also apply broadly to to other step-up pathways and other sorts of community rehabilitation recovery services. So there are 6 guiding principles to the model and 4 components. And I talked about the 4 components. The 6 principles, the ones I haven't mentioned as yet, as I said, the first one, requiring rehabilitation. Everybody who requires that rehabilitation has access to it. The interventions are therapy-led and delivered by a core multidisciplinary team with the ability to pull in that expertise when required. We're talking about an integrated workforce working flexibly with that one workforce culture across services and settings and sectors and building the relationships. We are talking about person-led and holistic support through making every contact count and reducing the handoffs, ensuring continuity of care. We're talking about new ways of working that are embraced, making full use of the range of skills that are available to a system or a service. And we're talking about distributed system leadership across organizational boundaries, driving the change that we want to see. And that's really, really important given, you know, some of the behavioral cultural barriers. And this is a new way of delivering, breaking through some of that risk averseness as well. Next slide, please. So in addition to what we described in the model and the framework, to complement the model, we also describe a therapy pyramid of expertise. And this describes the volumes of roles, and it doesn't describe or define the volumes, but it describes that sort of pyramid in terms of the volume of roles required based on level of expertise, where you have your more specialist workforce at the top and your more generalist workforce at the bottom in higher numbers. We've included some examples of the roles that could be used, and I suppose we included this in the publication because this is sort of a tool that systems could use to identify potential resources and roles within the community to help shape their models and think about, well, what actions do they need to undertake in order to utilize these roles to maximum impact? And again, everything we're describing is all about getting the right intervention at the right place at the right time by the right person with the right skills. A couple of points on the intermediate care framework. There were 4 sections, which I'm assuming everybody's seen, one of which was around workforce to increase capacity and support demand management. And the workforce sort of area, the section, was largely focused on the rehab enablement workforce and how to improve therapy capacity, thinking differently about what's accessible, what's in the community, and again, that split between your registered and your unregistered workforce. It was largely broken down into 6 actions or areas of focus, and what we suggested the systems can look at those areas and then start to think about looking at their demand and defining the workforce required to meet the demand, looking at what workforce they currently have in place, and then identify short-term and longer-term actions to close the gap, really translating that demand into workforce capacity and capability or skill mix, and then feeding into aligning with wider system strategic capacity demand plans. And to that end, some of the work we're now undertaking is working with 7 local geographies, place-based and a couple in ICB footprint to help those systems define what workforce is required, so translating that demand into workforce capacity. The work is running until end of March, so end of this month is the first phase, and there's some really interesting learning coming out, which we'll hope to share out quite nationally and think about, right, what are the sort of operational processes that you could do to help improve your workforce planning, get the right skills available at the right point in time. I'll stop there, Lauren. I was just going to say, unfortunately, I am on a site visit, so I will need to dash, so I won't be around for the Q&As, but anything, please do ping over to me and I'm happily obliged.
Thanks so much, Priya. Yeah, we greatly appreciate you squeezing us in, and yeah, we'll feedback if there's anything that comes up through the Q&A. Thanks a million for your time. Super. Right, I think I'm up next as well. Thanks, Abby, for moving that on. You can move on one more. Fab. I've realised I missed one of my introductory slides, which is quite an important one, which is in terms of what's going to happen with this information afterwards. So we will be sharing this recording with our NHS England colleagues so that it can be hosted on the Future NHS collaboration platform. On my slides, which will also be available, there is a link that tells you how to access that space. We'll put it onto the RCOT website as well. That will be open access, so you won't need to be an RCOT member to use it. And I believe my counterparts at CSP and RCSLT will do the same thing. So you and your colleagues will be able to access the slides and the recording afterwards. And I really recommend the Future NHS collaboration platform to you. I've popped a link to the intermediate care framework and to the rehab model into the chat, just in case any of you are brand new to this work. But I just wanted to pick up from a professional body perspective and build on a couple of the things that Priya said in terms of why we feel that this is such an important document and resource for occupational therapists and the wider AHP family. Because I think when you hear the words intermediate care, you can quite quickly interpret that that's quite a narrow remit and quite a narrow focus, and perhaps it is just a bedded service. And of course, that bedded rehab is a crucial part of intermediate care. but actually what's clear through the framework is that it's much broader than that. I think the other thing that feels really important about the framework is that rehabilitation is front and centre, and not just rehabilitation, therapy-led rehabilitation. And you folks out there watching this are the experts in that. And that's not just rehab that's delivered in bedded settings, as wonderful as that is. That's also very much about how people come back into the community, how and where they're receiving reablement, how they're accessing community rehabilitation in the longer term. So I think this little cluster here, this little honeycomb, are probably the key services that are most aligned and kind of ingrained in the principles of the intermediate care framework, and that cuts across the NHS and into local authority as well, where I know a lot of reablement and a lot of equipment and housing services sit. Abby, if you can just press the button once more. But also it cuts across the whole health and social care ecosystem. You know, people are people. They have multifarious needs, as we all know. So I think something that the intermediate care framework really advocates for is a much more joined up approach. It's not about starting with a blank piece of paper. It's not about ripping everything up and starting again. It's about looking at the services that already exist, some of whom are doing brilliant work, and thinking about how we can join up together, how we can maximise our collective workforce, because we know that you're all stretched. We know that it's difficult out there. So how can we, as Priya said, get the most satisfaction for you as practitioners and the best service for people using your services with the resources that we collectively have? Next slide, please. And that is my spiel to hopefully get you on board with how and why I think this is relevant to you, regardless of your area of practice. But also it's not just about where you sit within your different teams. It's also about your own level of practice, how, you know, what your individual role is. Because something else that the intermediate care framework is very clear on is that we really need the expertise of people at all stages in their career, of all levels of experience. It's very much about having allied health professions in leadership positions throughout the system. We know that we need more of us in those senior positions, and that's something that professional bodies are really working on alongside our members. Of course, it's about our registered therapists, but it is equally about our support workforce, our fantastic therapy assistants and support workers who we know deliver a lot of the rehab interventions. So how can we make sure that all of us has the input, the supervision, the confidence and the training to do what we need to do on a daily basis? Next slide, please, Abby. I will shush in a minute, I promise. But in terms of what do I think you need to do? Well, I think, as I say, AHPs are front and centre of this work in terms of the language of the framework, but you can't take that for granted. So you need to make sure that you as AHPs have a voice in your systems in this work, because you undoubtedly have the experience and the expertise to contribute. It shouldn't be happening without you. So ask those questions about how you and your AHP counterparts can and already are involved with implementing the intermediate care framework. Do take a look at the rehab and reablement model as well, and consider how your services line up currently. It could well be that you're already doing things that align with the principles of the model, and it really should be a tool for you to use rather than something for you to be beaten over the head with. So like I say, it's not about ripping everything up and starting again. It's about going, okay, is there a way that we can evolve that makes the working environment more productive and more manageable for us as practitioners, and helps us to deliver great services to the people who need us? And finally, I've mentioned the future NHS collaboration workspace. It's the key place, I would say, to keep in touch with what NHS England are doing to support implementation, but also to hear from the front runner sites and the pilot sites that Priya mentioned, so that we can all learn from those who have gone before. And we're lucky to be joined by 3 of those said people in just a few minutes, who are already doing fantastic work in Leeds. Right, I'm going to shush and I'm going to hand over to my speech and language therapy friends. I'm not sure actually if that's going to be Judith or Claire, because I know Judith was having some tech issues, but I think she might be in the room. So I will hand over to one or other of you. Are you there?
I am here, but my camera isn't working. So I think that's probably a great relief for everybody, but I made it. Hello, everybody. I'm Judith Broll from the Royal College of Speech and Language Therapists. I'm really pleased to be here with colleagues, because this programme, I think I'm not going to even try starting to tell you how grandmother sucking eggs. You listening to this webinar are the experts in this area. And actually, my slides really are just to echo what Lauren has already said. And actually, I'm really looking forward to hearing what people on the ground delivering this work have already done. For me, if I could have the next slide, the intermediate care framework, I think, offers all AHPs an opportunity to build on what we already have. Now, as Lauren has said, and I absolutely agree, we are all really focused and cited on the fact that on the ground it's really tough, and it's quite hard, I would imagine, to think creatively once you've got to keep the wheels on the bus at the same time. But longer term, this offers an opportunity for us to take what we already do well and to expand or grow or think about how we can do things differently. So absolutely, it says it right front and center of the framework to maximize therapy input and to support new and blended roles. I think we're already doing quite a lot of that. And also think about the breadth of the AHP workforce. If you do have any headspace to think at all, and hopefully, and I know that our Leeds colleagues have already done this, some of this work, is to think about different people. Are you the person, absolutely front and centre, the right person to be delivering that work? Or could your skills and knowledge be used elsewhere? And could you pull in other colleagues that maybe are not traditionally working in that role? I'm just putting it as an opportunity for further discussion. I'm not asking you to do that, but just as an invitation. Because I think if we can all really work at the top of our license, to quote Beverly Harden, but also to really push our boundaries about what is key and core to our own special needs and what is, whether in other people's remit, and really think about what the person at the center of our care really needs. That's not just physical rehabilitation and enablement, it's about their cognitive, communication, mental health needs as well. Now that may feel slightly out of your comfort zone, but that's okay, because we know, as Lauren's already pointed out, we are sitting in a honeycomb ecosystem. So it may be that our role is a signposting role here rather than to do the doing. And I think it's really important that we are all excellent clinicians in our own right. It's an opportunity to really use our unique identity as a clinician, but think about how we can really embed this with multidisciplinary colleagues. And we're often very surprised to see who that is. I think looking at the local population as well will really help inform that, and that may look different on different footprints. And I know my colleague I'm about to hand over to, Jack, is going to talk more about data in that, which is a beautiful segue. But I really would salute everything that you are doing now. Please, we're not throwing the baby out with the bathwater with this. I suspect we're all doing quite a lot of this work. We just maybe not know it as intermediate care, but actually this is a really good opportunity to take this integrated care framework and do something new and different with it once we have long enough to think about it, and hoping that this webinar is going to give us some ideas about how to move forward. So I'm now going to hand over to my colleague at CSP, to Jackie. Thank you.
Thank you, Judith. Hopefully I will appear. I've appeared. Brilliant. So as Judith has said, my talk today is, or a little bit of the talk is going to focus on priority 4 of area 4 of the intermediate framework, which is on data. Data is an enormous topic, and I could talk for the whole hour on data, and don't worry, it's only going to be a couple of minutes, so we can get you to listen to Leeds, who are the great frontrunner sites, as soon as possible. But the data that you collect and how you use it and who with is really key across the intermediate care framework to showing the good work that all AHPs are doing. We know that services are really easily able to talk about their outcomes and the benefits that they have for patients, but being able to evidence this with robust data, particularly in community services, has historically been difficult. The data has been varied, collected in different ways, and not used to the best of its advantage. So the pilot sites for the framework and NHS England are working towards a national data set, but this works in quite early stages. But in the meantime, there's actions you can take as a team and within your local area to start your data journey. So the most important thing is collecting data that is really going to show the meaningful impact and the value of your service on the quality of life for your patients and to wider stakeholders. So this might mean that your data doesn't just focus on the time that you necessarily have a patient, but looks at that bigger picture across the services and across the pathway. So like Lauren said, linking in with the other people in your honeycomb, where are the Bs of the patients going, and how can you link in with those? So the number of people that your services see and the length of stay can be really useful for showing activity, but they don't necessarily demonstrate your impact. So are you reducing length of stay in an acute hospital? Do your patients have a reduced care need from admission to discharge? So all of this data can be really powerful to show the great work that we know is going on out there for your patients, and also to show that economic benefit of your services and that wider societal value to your service and to people around you in your local area. Sorry. So talk to people who refer into your service and who you refer out to. So are they already using outcome measures that your team could incorporate? Is there an easy way that you can hand over this data? So as part of referral information or as part of discharge summaries, what we want to do is reduce that data burden. We don't want people to necessarily start collecting whole data sets, but to work with the information you've got, make it more efficient, see if you can extend it across that pathway, and so that you can track changes across a longer time. We're much more powerful, we have much more impact as we all work together. So if all the areas in your local area can get together, look at your pathways, look at what you're collecting, can you provide that information in a wider way to support your services? The other really important thing is to find out who the data people in your organizations are and to make friends with them. They can really help you and help you get on board. And we want AHPs to be part of that process. So starting to shape services, starting to have that voice in what you're collecting and how you're using it. So look at your current pathways and the data that you collect. You need it to be able to come back round to you in a really easily accessible and usable way. And we know that there is absolutely nothing more frustrating than collecting and submitting data that never then sees the light of day again. So think about when that data comes to you, who's going to see it? What do they want to know? Are there ways that you can present it to make the information really clear, really easy to read, and really easy for people to understand, both at patient level, wider stakeholder level, and within your teams and across your pathway? And lastly, before I hand you over to the fantastic leads teams, don't forget about the patient and staff voices. So collect those experiences and feedback that you can use to shape your services and to help tell the stories of the people who come through your services and really bring your services to life. Thank you.
Oh, hi. My name is Jen Throp and I'm the Programme Manager for the bed specific project in Leeds, but part of the whole Home First programme. And we're one of the front runner sites. So I'm joined today with my colleagues Laura and Brenda to talk you a little bit through the story of what we've done in the last year and a half, and then moving on to talk about in more practical terms the impact that's had on patient outcomes and patient care. So we'll move between us, but I'm going to go first. Next slide, please. So why did we redesign intermediate care in Leeds? Too many people were spending time in hospital for longer than they needed to, and the short-term care provided in the community was provided across many different services. So we had different contracts with different providers, different bed bases. There wasn't equity in all of the provision because the contracts were set up at different times with different focus. The outcomes for people varied depending on where and when they were supported, and we had a really high bed-based care use. The more beds we opened, the more we filled, and the longer people were staying, but not necessarily with better outcomes. So we really wanted to have a focus on reducing and avoiding deconditioning in older people and the impact that had on their independence and long-term care needs, and how we provided that as intermediate care services across Leeds. So what did the evidence say to drive that ambition? We undertook a diagnostic. So a diagnostic being that analysis of the data that was already captured about the flow across the city through acute to intermediate care services. But we also did really large scale tabletop case study analysis across all the partners in Leeds. And at that time, I worked in a bed base. I'm an occupational therapist by background, and there was a real large scale city of Leeds, all sitting in person, multiple different occasions, really analysing patient cases and their travel through the system and the offer in Leeds, and where the gaps were and where the opportunities would have been, or what we might have done if we could have had a bigger ambition for what services could be provided. And as a result of all of that data capture, they identified that over a 12-month period, 400 plus more people could be supported to recover at home, rather than stepping down into a short-term rehab bed, and that people were spending twice as long in the community bed than their case study would suggest was necessary, and they could have moved on to intermediate care rehab provision that was home-based. In order, we could have avoided 1,700 people in a hospital admission, and that was multifactorial. That could have been staying at home for home-based rehab, step-ups into short-term beds, and admission avoidance at the front door. And really powerfully, over the course of 12 months, there was 100 cases where people could have avoided going into long-term placement. So that was what gave us our drive and ambition. Next slide, please. So we created the Home First programme vision, and we had 3 priorities. For the people using, for the future users, we would have better and more independent healthcare outcomes. We would reduce unintentional harm that the system caused, people waiting in hospital beds, waiting for the flow to come out into the community, or being admitted unnecessarily, or not being able to start some of the home-based services as quickly. And that we would have simplified services with improved communication, coordination and compassion. For the system, we would simplify our offer that was currently fragmented due to all the different contracts. We would support system flow. We'd have better visibility, and would reduce pressure and some of that surge pressure and drama. We would have more consistent overview and would be able to prevent future surge, and would also be more financially sustainable. And for folks working within our systems, we would reduce frustration of the delays, lack of capacity. We would make life simpler with more patient-focused processes, and would improve tools and communication systems. Next slide, sorry. I should be slicker at saying that. So we created 5 interdependent projects. We're here today to talk about active recovery and rehab and recovery beds, but there were 3 other projects at the same time. Enhanced care at home. There was transfers of care, which looked at the way patients travelled between hospital and care settings and how many times they were triaged, and looking at over triage, and also documentation, and how we shared, how many documents we didn't share and what we did share. And then system visibility and active leadership, which is where the data focus has come from for this overall programme. Next slide, please. And I'm now going to pass on to Laura for a more practical talk through active recovery.
Good afternoon, everybody. So just following on from Jen, in terms of the active recovery at home in Leeds, so the active recovery service consists of Leeds City Council reablement staff and Leeds Community Healthcare, so NHS therapy, so that's both physiotherapy and occupational therapy. And one of the projects was to create a pilot team where we created a team of LCC, Leeds City Council reablement, and NHS therapy staff working together as one team. So you can see on this slide that a referral historically would have been sent to Leeds City Council reablement or to the NHS in separate pathways. teams were based in different locations, and working together was really quite limited, other than occasional phone calls or MDT meetings. So having this joint team that integrated together, we created one referral pathway. So the referral for either reablement or therapy was sent to a central hub and then triaged together by reablement and therapy. So making sure that that case is therapy led and rehabilitation is at the forefront of what that person needs when they're discharged from hospital. So in terms of doing that, we were then able to identify cases that would benefit from a joint reablement and therapy assessments. So historically, we'd have patients being discharged from hospital. If they needed reablement, they'd be referred to reablement. If they needed therapy, they'd be referred to therapy, and they were working separately. But the benefit of the joint team working together, if they had both of those needs, we would visit and do a joint assessment together. So obviously that's a much better experience for the person who's receiving the care, because they're not telling their story twice, having two separate teams involved. And also it's better for the therapist involved, because they're working with reablement and they have oversight of what's happening day to day, and also for reablement in terms of having a therapist to do that joint visit. So many benefits of working in that way. So what we also set up were joint weekly MDTs. So working as one team, we have a weekly MDT. We had joint daily huddles. So every morning we'd log onto a huddle and talk about the caseload. And we developed a joint MS Teams space. So I'm sure that lots of people listening to this call now are thinking, well, there's two separate services, two separate systems. How have you worked together? And how we did that was through the use of MS Teams. So we created a Teams channel where we could chat to each other, raise any feedback, etc. And we co-located to be in the same base. So we were located together as a team. Next slide, please. So this slide just shows a case study example. So again, thinking back to prior to this pilot, which is very much based on the intermediate care framework of integrating community reablement and community therapy together and having more of a therapy-led reablement. I thought I'd share a case study. So this is an example of it's not a real name, so it's anonymized, but this is an example of a case where we've looked at the referral together. And this case historically would have gone to two totally separate teams who are not based together and not necessarily working together in the way that the pilot team is. So this is a case example of somebody called Julia. So Julia was being discharged from hospital. So historically, she would have been referred to the reablement service for personal care, daily living visits. And what we found in the pilot was that reablement had more of a providing care approach, and actually having a therapist and having that rehabilitation focus. Doing that joint visit, we were able to actually bring in more of a rehabilitation approach. And also by doing that visit jointly with therapy and reablement, we changed it to be very goal-based. And you can see to the right that on the MS Teams channel, what we did was therapy that we're visiting. So we put support plans in place, and one of the referrals we made was for assisted technology. And then obviously we did the risk assessments. But you can see on the right of the screen that the goals are the same. So the goals for reablements and the goals for therapy are aligned, and they're the same. I'm sorry that it's very small, so you can't read the detail, but what you can see is the colours along the side. So we know that reablement and therapy are both visiting a patient, and we can see where they are with their reablement goals and where they are with the therapy goals, and those goals are aligned. So for Julia, prior to working in this way, going to two totally separate services, having two different assessments, actually the goals for Julia would have been, I imagine, very different. Whereas now, having this integrated way of working where we visit together and we align our goals, it's a much better experience for Julia. And not only do reablement have sight of what the therapy goals are, but the therapists involved have sight of what reablement goals are and whether those goals have been achieved or not. So we found this goal tracker that we could both use on a Teams channel really, really useful and beneficial in terms of rehabilitation. Next slide, please. So I've talked about how I would describe that we're aligned as reablement and LCH NHS therapy. So we're based in an office together. We triage referrals together. We do joint visits, but we're now moving into what we would describe as phase 2 of this integration. And I thought it would be helpful just to briefly share the key areas of work that we're now doing to move this forward. To ultimately, the aim is that a year from now, we will be based in an office together, and it doesn't matter what badge you're wearing. It doesn't matter whether you're council based or NHS. We're one team. We work together. We make the best use of our workforce and our resource. That's the aim. And to allow us to get there, from learning from the pilot, the 4 key areas that we're going to be developing is firstly the leadership. So we have Leeds City Council reablement and NHS therapy working together with 2 different leadership structures, and actually we feel having one leadership structure overseeing both of these services is what we want to try and achieve in phase 2 of the Leeds Active Recovery. The next area is around our workforce. In fact, I'm going to come on to that. I'm going to talk about the single care record first. So we have our Teams channel, which is a short-term solution. So we had to think about a short-term solution that we could use and be creative and try and think outside the box. How can we work together? How can we have sight of each other's goals, etc.? But what we need is a single care record where both reablement and the NHS are on the same record and can document in the same place. And once we've achieved that, then we will no longer need to do that joint assessment on discharge. We would just have one therapy assessment, and then we could obviously delegate to reablement. So once we have that single care record, we're going to review our workforce and just ensure that we've got the right workforce. And actually, going back to what I said at the very start, prior to active recovery, these were 2 totally separate services. So Julia would have been referred to 2 teams, and now Julia's being referred to 1. So you can see the benefits of that. So actually our workforce will slightly change if we are changing our rehabilitation offer and we're making better use of our workforce. And the area that has been, I'm going to be very honest, has been one of the more challenging areas is thinking about how do we delegate from one organisation to another. So how, as a registered occupational therapist, do I delegate to Leeds City Council support workers? And what we have agreed is that we need a competency framework. So the support workers need to understand what the occupational therapists and the physiotherapists can and cannot do, and vice versa. So as a registered therapist, in order to delegate to a support worker, it's really important that we understand exactly what they're competent in, what they can and can't do, what equipment they can order, etc. So a big piece of our next phase of work is to develop this competency framework for the whole active recovery team, using a lot of resources that we already have from professional bodies and bringing some of that into the work we're doing. So that's just summarising some of the next steps. And I'll pass over to Brenda. Thank you.
Lovely.
Jen,
The next section is, so Brenda and I are going to talk about rehab recovery beds together. So essentially we have multiple partners working over 6 hubs in Leeds. So we have a huge bed base. And similarly to Laura, we had to really work with stakeholders to stop focusing on individual policies or procedures, depending on which organisation, private, health and social care that worked for. But by doing so, we brought together a project team, and we had a focus on what good looks like now, what our ambition is now with our current workforce and our current financial envelope. Although we have an opportunity to put that into contract for 2025, we're working collectively in the best interests, with our patients, customers at the heart of all of our care. And we've created some components to drive that change. So the things that we have done differently are to introduce a dedicated social worker for each bed base, rather having a collection of social workers, and they stay for the whole day for the MDTs. So they're part of conversations, they can preempt difficult conversations, they can support and give guidance to the MDT. The whole team rehab model is a real focus on a strengths-based goals plan, on which everybody within the hub offers that to the individual. So the care staff that are there more times during the day than any of the therapy staff, either registered or non-registered, have sight of the care plans that is goal-based. So if a family member comes in and says, how many occasions has my mum had physio today, which was previously a big challenge, we now can say, the carers can say, there'll be varying levels of confidence in this. Well, actually, their mobility plan is to walk to the dining room, and they've had their meal out 3 times today, so that's been 6 walks, and that's been in addition to the physiotherapist and occupational therapist and the teams that are in. And we've also had a more formal structure to the MDT meetings to really create a chair so everybody's voice is heard, even quieter voices, and a respectful challenge role. So there's a focus on SMART goals. Well, how many days will we focus on that and then review? We then have progression and tracking meetings. We have a daily handover. So there's more of a drumbeat about some of the decisions that are made in the hubs as a collective group. So what is the next domino that needs to fall as part of that rehab journey and following the goals plan? Who's going to do it? We have an admission and discharge coordinator role that really captures that. It's a shared document, regardless of organisations, everyone can see it, but that's the daily drumbeat. And it also draws down on the night staff's knowledge about, I know that that's their goal, but actually they've started doing it for themselves, or that's a daytime goal, but during the evening, we're not able to achieve that. Can the therapy team during the day feed back to us and give us some more support and guidance? There's a performance visibility dashboard, so the data that's captured at the MDTs and at the daily meetings, which has the goal on it and multiple other items on it as well, is pulled through onto the performance visibility dashboard for the city. So all hubs can view this, and city leadership can view it as well. And that marries up with the reason to reside and no reason to reside data, admissions, lengths of stay data, and that's where our KPIs come into that. We have really transparent visibility now on length of stay and percentage of successful discharges home. That falls into an operational governance structure. We've included discharge planning conversations from day 1, where we record what the estimated discharge date is, and that can change, but we keep that as a focus for the group because the short-term beds have a time limited offer in the city, and we've really had a focus on the value of that and the role that they play to create a collaborative exit plan with patients, with service users and relatives and the MDT, in order to support flow downward stepping from the acute services and stepping up from community services. And then we've introduced a pharmacy tech role, and that does have relevance here, because what we have found now, by having a focus on self-medication and independence, really supports an individual's volition within the service and their sense of self, and taking one key aspect of independence and care at home, and that has had a real positive impact on their engagement with therapy, drives to go home. It's had a secondary cost implication, which is we're not relying as much on home care to provide that and we've not accidentally de-skilled someone because we haven't had a focus on that. But that's been really powerful. Just quickly the next slide, and then I want to give Brenda time. The next slide was some of the challenges we faced, but you can read that in slow time because I know those have been shared. But what I wanted to say is we've used all of this to create what is the staffing model going forwards. And some of the staffing model exists as this current provision in many of the hubs. But Brenda and I met when we were part of a team that was set up as an integrated workforce that had a view that we shouldn't be in-reaching for dietetic and speech and language support from community partners into the hubs. We should have an integrated hub AHP and MDT workforce. So Brenda and I worked on that together for a year, and it was so successful but not equitable across the hubs. That has been a real key component to what we've costed into any future modelling. So OT, physio, dietetic, speech and language therapists, pharmacists have been a real core focus of the remodelling work. And I'm going to pass over to Brenda now so she can describe why that has been so important and that's been pivotal to our remodelling.
Can we have the next slide, please? Thank you. So yes, like Jen said, I was working with her on the bed space with the MDT. Sorry, excuse me. Prior to that, I was working in the community in a unit disciplinary team. So the community referral model was what was used prior to that. And like Jen said, it wasn't equitable. So in the other hubs that we weren't working in, that was the model that was in place for people that needed speech and language therapy. So as an example, we've got referrals sent to community teams. The urgent response time would be between 2 and 6 weeks. Quite often the people there wouldn't be under that urgent remit. There would be a routine, and those response times are significantly longer, upwards of 18 weeks as an absolute minimum. So quite often people wouldn't get seen in the recovery hubs or in those spaces because the length of time that they were there. So the outcomes there were there was a delayed response to the patient need, there was reduced nutrition for them because they weren't eating and drinking as safely as they might have been, or that wasn't identified as an issue as quickly as it might have been. And because the team in the community were working in a unidisciplinary way, it was difficult. It took a lot of extra time. There was limited access to complete the information for the patient. And essentially it was the incorrect patient journey based on the experience that we've had. So being integrated in the MDT meant that I was able to attend the meetings daily. I was involved in staff training and helping everybody understand the importance not only of swallowing difficulties but also communication difficulties that these people were experiencing. Excuse me. So what we did was with setting the SMART goals, maximising the patient's communication support to be able to be involved in that and to have the patient at the centre of all of this, and ensuring that we managed the risks that were identified in relation to them communicating, but also in swallowing, and managing that quite effectively. A lot of what I did was educating the team around the patients, so the carers, the nurses, the rest of the MDT, and identifying any difficulties that patient might be having. So it was picked up really quickly, and quite a lot of times may not have been picked up at all. So we talked about the community referral model, and patients might not have been picked up at all if it hadn't been identified and shared and everybody being more aware of that. So the outcomes there were we had a model of referrals by listening to the safety huddles. The referrals were received really easily by myself on site, and people got to know very quickly how to do that. There was a very urgent response and very quick turnaround, likely within a day, that patients were being seen. And that was intervention for both swallowing and communication. It reduced the risk of aspiration because it was identified quite early on when people were having difficulties. So therefore, it wasn't as likely to lead to more complications as we went through. Overall, we felt that there was improved therapy understanding. the patients and their ability to identify the symptoms of concern. So that was how we were working. But the easiest way of explaining all of this is probably a patient example. So the next slide, please. I'll just go through that. So again, I've got an anonymized patient called James. He came into one of our rehab beds following admission for COVID. He'd not had any speech and language therapy in the hospital, and it wasn't indicated at the time. And physiotherapy had been provided in hospital, but no other professional was involved. When he turned up at the rehab bed, the carers noticed that he was coughing when he was eating and drinking. And then with discussions with family, they highlighted that he'd had some weight loss and they were concerned about his general understanding of what was happening. I went to see him the same day that the family had raised this. And sorry, just a second. What I helped initially with was for ensuring his understanding when he was having the input from the OTs and the physios, so that his daily activities were improved and his mobility was improved as well. Because of the coughing being notified, I assessed him for swallowing and identified that there was a possible link to some difficulties that he'd been having. And I think what had been missed was because he was quite a heavy smoker, it was put down to his coughing was related to his smoking rather than thinking it was related to his eating and drinking. So I provided some recommendations to everybody involved. Sorry. With that became the immediate change in his care plan to minimise the risk that was involved with him eating and drinking. But I also arranged for a video fluoroscopy, which identified that he'd actually had a very unsafe swallow. And it was the most unusual swallowing difficulty I think I've ever seen, because he had more difficulty with pureed food than he had with regular food, which was highly unusual. And then as a result of all of that, I was able to work with the catering staff and the carers to make sure that he could have the food that he not only really enjoyed, but also making sure that the food was adapted to suit his needs. And it wasn't just a case of putting him on pureed food, which quite often happened in care settings. Because he was having the food that he enjoyed and because he was taking a lot more in, he was then able to have the energy to eat and drink well and participate well in his physiotherapy and his occupational therapy. And he returned home quite soon. So he joined us in December and he went back home in January. And when I was putting this together, I did review what had happened since, and it was very clear all the way through the following year that it went back to the best interest decisions, what he really wanted to eat and drink, and how things could be adapted to make sure that he could eat and enjoy what he most liked. So good patient journey there. I think that's all I have to say on that one. Don't know if you want anything else, Jen.
I think what it showed us when we had both
Sorry,
yourself.
I'm so sorry, Jen,
sorry.
to interject. I'm just aware we've gone over time, and I realise that is on me because we did start a little bit late. If you folks are happy to run on a few minutes, I know that probably attendees will need to leave. We are recording this session though, so if people do need to dash off, hopefully they can catch up. Jen, Laura, and Brenda, are you happy to keep going for a few more minutes? Because I don't want to curtail what you're saying, but I'm also just a little bit mindful of the time, and you might have other meetings to get to yourself.
No, I've got another 5 minutes. Yeah.
Fab. Let's go for it then. Thank you.
So it was just that I don't think we can overemphasize the impact of having Brendan, our speech and language expert role, and Emily, who is our dietitian in the model we worked with for a year. We can't overemphasize the impact that had on our individuals' ability to successfully engage in rehab as a result of it. It did open the team's eyes, the OTs and physios that we worked, of which I was one of the OTs, as to as how the four professions needed to work together for the best outcomes. And it was also really useful working alongside our SALT and dietetic colleagues to think about I think previously as an OT, I'd always made sure someone had a glass of water after we'd done an intervention or such, but it helped us have the bigger picture of this person isn't hungry at the beginning of the day, but actually by the time you've gone in and done, say, a bit of standing work or a bit of personal cares, they'll be starving. These are the sort of foods that they can have. It was a bit more than just than what I previously as a therapist would have thought was the standard diet or some of the supplements. We'd started making normalised supplements on the ward, but we'd also factored that in with the consistency of diet for some of our customers, and we were able to look out for some of the warning signs of someone having an issue with swallow, and then reduced participation and lack of appetite, and then lack of energy to engage. And we were able to alert Brenda and Emily about that, as well as them coming to the start of the day meetings. And we can see where the absence of that in the hubs without them it puts pressure on the nursing and care team, and we could really do with that expert guidance and support, and that's why it's become a component part of what the new staffing model will look like. I think you've been modest, Brenda. And I think that is all we have to say. If I saw some questions in the chat and I tried to answer some of them, but perhaps they'll be shared if we can, and I'd be happy for my email to be shared.
Thank you so much. And yeah, apologies that timekeeping has gone a bit awry today, but this is the joy of recording things, I suppose, isn't it? There was so much in there. Yeah, we haven't got time to answer the questions live, but I've popped my email address into the chat bar if people do want to use me as a conduit, and I can feed things through to Jen and Laura and Brenda if they're happy to come back on things. That would be great. So much in there. I think to really kind of wrap up, I think you beautifully illustrated the power of data, of understanding where you are before you rush up and change things, kind of understand what the challenges are, understand what resources you have available to you, and really maximising that, and how there is huge strength in collaboration across professions and also across teams, and that yes, there are barriers to that working, not least single care records, but there are ways that you can do it, and it sounds like there's huge value in it, and that it actually makes everybody stronger. I don't get any sense of there being a stripping away of people's professional identity. I think the more we can share our skills with each other, the better we all become in our individual professions, and the more we can support each other appropriately. So enormous thanks to everyone for your time. That goes for all of our presenters and everyone who's watching at their desks as well. I've certainly found this to be a really helpful and thought-provoking session. If you've got the time and inclination now or later on this afternoon, please just help us check in again. Let us know if this has been a helpful session for you. There's also an option to leave comments if there's other things that you would appreciate perhaps more information on. Last slide, please, Abby. Details. This is me and Claire and Jackie, my CSP and RCSLT counterparts. You're very, very welcome to be in touch with all three of us from your respective professions. If you are getting to grips with the intermediate care framework, if you're already doing things, if you're thinking about things, if you're having challenges, please let us know so we can support you as your professional bodies. And we will wrap up there. Enjoy the rest of your afternoon, everybody. Thank you ever so much for being with us. Cheers.